First, I want to thank Angela for the kind introduction. We miss you here at CHOP. I also want to thank the meeting organizer for inviting me here to discuss our experience and how we use integrated genomic profiling of pediatric brain tumors and use those data to drive precision cancer care. So as we all know, children are not simple small version of adults. So the same is true. The pediatric cancer is not a small version of adult cancer. So there are some special features about pediatric cancers, and every year about 16,000 of pediatric cancers diagnosed in the United States, and brain tumors account for about 25% of them. And if you look at the cancer predisposition, and we've found more than 10% of the pediatric cancers are hereditary, and it is much likely higher for the brain tumors. There are very few FDA approved drugs that is specific for pediatric cancers. I am so happy to see there are a few of them now. And although pediatric cancer has much better long-term survival rate compared to adult cancer, and about 2/3 of them will have some long-lasting effects. So that's why cancer genomic diagnosis profiling are very important. We want to stratify patient risk accurately so that we don't overtreat the patient nor undertreat the patient. And in order to be able not only improve the patient survival rate, but also preserve their quality of life. So when I talk about integrated genomic analysis, which means we use multiple different tools based on different diseases and what material we have. In our lab, we use cancer cytogenetics, that's study of chromosomes. We use the FISH, we use microarrays. We also use some old single gene technologies such as MLPA, Sanger sequencing when it's needed. We design specific test for single patient, and because that mutation may be only in that patient, and that is critical for us to trace that specific marker to monitor patient response to the treatment and to identify residual diseases or early relapse. We also offer pharmacogenomic testing, and that will inform our oncologists to use the right dosing for specific drugs. Lastly, certainly not least, we use next generation sequencing technologies, and we do either targeted multi-gene panels or we do genome-wide sequencing. So unless you do whole genome sequencing, you have to have a methodology to capture your region of interest. And so what we use here is we use SELECT from Agilent. Not only we use that to design our region of interest, but we also put in SNPs, and that help us to do the copy number analysis. It's like a low density array. And not only you can look at log-R ratio, but also look at the B-allele frequency. And this is important for pediatric cancers, which often have ploidy changes. And we also put in the SNPs, and that is one of our QC measures, and that is the patient ID. We ID them separately. And so we bioinformatically put them together to make sure the data we pull out is from the right patient. For the RNA-based test, if it's a panel, we use Archer multiplex PCR technology, which is like a one-sided PCR. And as long as one partner gene is in your panel, you will be able to identify any translocations associated with this gene. This slide shows the complicated bioinformatic pipeline for our cancer transcriptome sequencing. We use this test not just for the gene expression, we use for fusion calling, and most of the fusions are drivers in cancer. We do gene expression analysis as well, and that helps us to identify different gene expression signature, not only for diagnosis. Sometimes we may be able to identify specific therapeutic markers. There are times we also use RNA-seq for variant calling, and this helps us to prove a variant we identified that's actually expressed, and also help us to elucidate if a splicing mutation that actually is clinically significant, and maybe that will include a specific exon or skip a specific exon. So this is what we validated for clinical purposes. All the variants we identified are classified based on AMP, ASCO, and CAP guidelines. I don't have time to go through the whole guideline, but I want to allure your attention to two tiers. Tier 1 is variants with strong clinical significance. Tier 2 is variants with potential clinical significance. And this is based on available evidence to show those variants have either therapeutic or prognostic or diagnostic significance, or they can have multiple significance. This is the data we published about 2 years ago now on 367 patients we sequenced in our lab. And we identified about 79, close to 80% of the patients who had tier 1, tier 2, or clinically significant variants identified. Among those, 72% with diagnostic significance. And you can see, and about 3% of them were actually because the identification of those variants changed histological or pathological diagnosis. About 50% of the patients were identified variants that has prognostic significance. About 44% of patients were identified variants that has therapeutic significance. Of those, 36% with potential change of treatment based on the prognosis, and 12% with potential targeted therapy. And approximately 20% of the patients, among those, we identified a potential germline variants. When I say potential, because at that time we only do tumor sequencing, we now have about 1.5 years we've been doing both tumor and normal paired analysis. And this is about brain tumor only data. As you can see, there are 90% of the patients were identified variants with diagnostic significance, 83% with variants with prognostic significance, 78% with therapeutic significance. Among those, 78% with potential change of treatment based on prognosis, and 5% with potential targeted therapy. 27% of the patients with potential germline variants. So this is the data we summarized recently, and that is until the end of June of last year. And we tested about 500 pediatric brain tumor patients, and they were aged below 21 years old. On the left side, that shows where the age difference as well as the gender difference. So I don't know whether you can see my cursor, but I'll put this. As you can see, there is no difference between male and the female. The age is very comparable between male and the female. The tumor we tested across 25 major subtype of brain tumors. As you can see, most of them are, of course, gliomas that include both high grade and low grade, and with low grade as the most, and followed by embryonal tumors, and then neuronal and mixed neuroglial tumors. This slide shows what are the variants we identified in those patients. 53% of the patients shows tier 1, tier 2, SNV and indels, those are sequence variants, and 62.3% showed tier 1 or 2 copy number variants. That just shows how important copy number variants is in brain tumors. And 30% of the patients in those, we identify tier 1 or tier 2 fusions. If we put all of this together, 91.3% of the patients, we identified clinically significant variants. And they may have just one type of variants, but most of the patients will show 2 different types of variants that either SMV in DL plus CMV or CMV plus fusion or fusion plus SMV. So if we dive into more detail about sequence mutations, what are the genes got mutated? The most common ones are TP53 and BRAF, as you can see here, followed by H3F3A and NF1. Look at the copy number changes. The most common one are 7Q duplication and followed by 7P duplication and 1Q duplication and others. Regarding fusions, not a surprise because we have a lot of low-grade glioma. So the KIAA1549 BRAF fusion is the most common one and followed by a RENA fusion. But if we look at the genes involved in fusions, BRAF is still the number 1 and followed by NTRK and FGFR. So if we dive into one specific tumor type, for example, diffuse midline glioma, which is very common as a new entity in pediatric brain tumor, we see 100% with H3 mutations, which is not surprising. 50% of them will have a TP53 mutation and followed by PIK3CA, NF1, and PPM1D. And if we look at the copy number changes, and you will see 17P, gain of 1Q is the most common one, close to 50%, and 17P deletion, 13Q deletion are quite common as well. And then we know there are important tumor suppressors on those chromosome arms. And although there is no fusion identified in diffuse midline glioma, most of the patients do have both sequence mutations and copy number changes. This slide shows the tumor mutation burden. By and large, pediatric brain tumors has low tumor mutation burden, but we do identify there are some tumors with high tumor mutation burden. And if you look at those tumors, not surprisingly, we identify the mutations in mismatch repair gene and there are mutations and that lead to mismatch repair deficiency. Talking about germline mutations, out of 497 patients, we identified 90 potentially germline variants. And for those, we didn't do tumor normal paired analysis, and there is a follow-up confirmatory testing that will offer to the patient. As you can see, out of the 42 cases we did the confirmatory testing, 76.2 were confirmed to be germline. If I apply this percentage to all 90 patients, and we would identify, we would have identified 69 patients with germline mutation that predisposed them to cancer. Diving into what are the genes that is mutated as germline in brain tumor patient, TP53 took the gold medal, followed by NF1 and APC. The last pie chart just show you what are the brain tumors with the germline TP53 mutations. It's pretty diverse. So I'm going to switch gears to talk about how genomic profiling drives precision cancer care. As we all well know, recently FDA approved 2 TRK inhibitors for the adult and the pediatric cancer. This is important for pediatric ward. And if the solid tumor is not resectable or it's metastatic, and that can qualify them to use those TRK inhibitor. We know TRK fusions are not so common in most of the common diseases. But in gliomas and the reported percentage is about 1.4%, and that includes both adult and pediatrics. We look into our 450. We identified 11 patients with NTRK fusion. That is 2.2%. So this table shows some of those patients. As you can see, and most of the patients had a low-grade glioma, and they have NTRK2 fusion. There is one patient with ETV6 NTRK3 fusion. That is a patient with high-grade glioma. So if we look into all the pediatric cases, we found 2.2% of the patient with NTRK fusion. And if I take out the liquid tumors, and there are 3.1% of pediatric solid tumors with NTRK fusions. In the brain tumor, I just said 2.2% of the CNS tumors with NTRK fusions, and NTRK2 fusions is exclusively found in CNS tumors in our cohort. We do have one patient with NTRK3 fusion. Unfortunately, we didn't test this patient early enough. We only get the autopsy specimen identified this fusion. However, there are reported cases and patient with brain tumor, high-grade brain tumor responded well with TRK inhibitor. And this is a 3-year-old girl who was diagnosed with high-grade glioma when she was 5 months old. And she had gone through multiple surgeries, chemotherapy and radiotherapy. Unfortunately, the tumor kept coming back. It was the third surgery. They profiled tumor, identified this ETV6 NTRK3 fusion. And I want you to look at this MRI images. And so this is pre-treatment 2 months and 5 months follow-up images. Look at this enhanced tumor mass. This is a supracellular mass. After treatment, 2 months after treatment, that is gone. You don't see it there. And the response sustained at the 5 months follow-up. And look at this yellow arrow. That shows where the surgical bed is. And you see the recurrence of the tumor. And that is drastically improved after 2 months treatment and completely resolved after 5 months treatment. So looking at the low-grade gliomas, and those patients, and they have gone through gross total resection without additional therapy, and they have been doing very well at the follow-up. However, if we look prospectively, of course, we don't want their tumor to recur, but if their tumor progress or recur, and they can still benefit from TRK inhibitor therapy. The last case I want to show you is to demonstrate the importance to look into cancer predisposition. And the cancer predisposition does not have to be inherited. They may not have family history of cancer. So this is a 9-month-old female who presented to the ED with seizures and vomiting. You can see MRI showed large heterogeneous solid and cystic tumor, and that's centered in the right posterior cerebral. And you also see extensive leptomeningeal and ventricular dissemination. The pathology study is the diagnosis is pretty clear. It's ATRT with iron I1 not retained. So we didn't get to test the original tumor for with the next generation sequencing. And we tested the recurring tumor of this patient, and we identified no mutations in the genes in our panel, but we did find a duplication of chromosome 8. And as you can see, this is log-R ratio on the top panel. The bottom shows the B allele split and due to the duplication. I want to draw your attention to chromosome 22. It seems there is no copy number change by B allele, by the log-R ratio. But when you look at the B allele frequency, it's widely split. So that means there is a loss of heterozygosity. But if we look into that chromosome 22, enlarge them, and you will see these 4 green dots. Those are SMARCB1 exon 4 and 5. And this shows there are triplication of those 2 exons. And that means there are 4 copies of those, even though the rest of the gene is only 2 copies. So we went back to look at the original tumor, and we noticed through the study of patient history, the patient had kidney rhabdoid tumor as well at diagnosis. So this just gives you a sense, and there might be a cancer predisposition because there's multiple primary tumor. So when you look at the MLPA data on the first brain tumor, and you see 2 deletions, and that was at the time, and they explained the INI1 loss because they thought those 2 deletions might be on 2 different alleles, although I would really question if I see that result because that is very uncommon. And then when we look at the kidney tumor, and you don't see deletions, but you see gains of exon 4 and 5. And if you look at the ratio compared to normal, it's not a 1.5, it's almost 2, 1.8, 1.9. So I would consider that might be 4 copies of exon 4 and 5. So we got the normal kidney and the blood. We did not see anything gain or loss. But if you look at exon 4 and 5, you see the ratio compared to the normal, it's not 1. It's not around 1, it's 1.1 or 1.2. So based on all of this result, we come up with this theory, how this patient get predisposed to ATRT. So the patient probably has a post-zygotic mutation, and in one of the allele, and duplication of exon 4 and exon 5 of the SMARCB1 gene. And this is only in part of the cell, in one clone. So when you look at the MLPA, there is no duplication, however, in those 4 dots, and they have higher ratio. And in the primary brain tumor, that initiated from this abnormal clone, the normal allele got deleted. And that's why you see and most of the exons got deleted in the SMARCB1, but those 4 green dots, that's exon 4 and 5, they had 2 copies because there's a duplication. In the kidney tumor, as well as the recurring brain tumor, not only this normal allele deleted, the abnormal allele got duplicated. And that's why, and you see 2 copies of most of this gene, and but with the loss of heterozygosity, and for exon 4 and 5, there are 4 copies because of the duplication. So this result just shows us this patient had post-zygotic mutation that lead to cancer predisposition. And for this young couple, future children, they don't have increased risk to develop the same tumor. And this patient, of course, is referred to our cancer predisposition program for genetic counseling. So in summary, an integrated genomic profiling provides clinically significant diagnostic, prognostic, and therapeutic evidence. Clinically significant variants are found in more than 90% of patients with CNS tumors. 78% of the findings are with potential therapeutic significance, and if we only based on prognosis, or in other words, based on patient risk. And 5% of the patients, and we identified potential targeted therapy. And we also identified 18% of patients that they may have potential germline pathogenic or likely pathogenic variant, and that warrant further study. And our experience demonstrates that all pediatric CNS tumors should be genomically profiled to inform precision cancer care. So with that, I want to acknowledge all the people at Division of Genomic Diagnosis for their hard work. And Also, I want to thank our neuropathologist. We work very closely to each other. Last and not least, I want to thank neurosurgery and D3B for their continuous support to our program. With that, I will conclude my presentation. And if I have the time, I would be happy to answer any questions you may have. Thank you.